Okay, good afternoon, everybody. Thank you for joining us in this panel of experts to discuss about ovarian cancer. This is open to all the public. Our objective is to answer your questions. This is not a scientific meeting or a scientific discussion. This is main the purpose is to clarify any question that you have, concern, or things that you were afraid of asking. So in order to start, I would like to introduce the members of the panel, and I will ask each of the members to introduce herself or himself. Start with myself. My name is Gil Mor. I'm an MD Ph.D. I'm the director of the CS Mott Center for Human Development, and have spent many years trying to understand multiple aspects of ovarian cancer. Maybe we go from you, and we will end with you. Okay.
Hello, thank you for joining us. I'm Daniela E. I'm a medical oncologist at Northwestern University in Chicago. I treat patients with gynecologic cancer, and I also have a laboratory that's working on ovarian cancer. We are interested in mechanisms of resistance to chemotherapy in ovarian cancer.
Thank you.
Good evening, I'm Rhadika. I'm a GYN oncologist at Carnegie Cancer Center. My interest really is in detection, treatment of ovarian cancer, and obviously developing some new therapeutic targets which we can use to help increase the quality of life and really the survival of patients with ovarian cancer.
Thank you.
Good evening, I'm Ayesha Alvero. I am a professor here at the Mott Center at Wayne State University. And my research focus is understanding mechanisms of resistance and how ovarian tumors that used to respond to chemotherapy doesn't respond anymore, and try to develop preclinical studies to identify novel therapies.
Thank you.
Hi, I'm Megan Neubauer. I'm the executive director of the Michigan Ovarian Cancer Alliance, and so I'm so glad to be with all of these wonderful experts in the room here too.
Thank you. Ira.
My name is Ira Winer. I'm a gynecologic oncologist, member of the gynecologic oncology team here at Carmanis, and also a member of the phase 1 developmental therapeutics team. My clinical and research interests lie in bringing novel therapeutics to the clinics in order to also help patients live longer, but also continue to have excellent quality of life.
Excellent.
Okay, I am Mary Groll-Brown. I am here today as a 8.5-year survivor, but I also have my whole career in female health and clinical research at Michigan Medicine Early Medical Center in Saginaw St. Mary's, but I am here today as a survivor.
Thank you, Mary. And we have also Dr. Rutherford. He is online. Dr. Rutherford.
Good evening. I'm Tom Rutherford. I'm director of GYN oncology down at the Morsani School of Medicine in Tampa, Florida. I've been working GYN oncology for the past 30 plus years. We do a lot of high-PEC intraperitoneal chemotherapy that's heated during the surgery. And my main focus and interest has been ovarian cancer over the years.
Thank you so much. And I think I didn't forget anybody. So again, I want to thank the panel for joining us late in the evening. And we have a good number of people assisting. And again, this is a conversation. So I will start with a couple of questions to warm up the public, and then we will open to anybody who is there to bring their own questions. Some of the questions that I have here are from patients who sent that to us early. So, and that is the reason. One of the first questions that we got is about early detection. Yeah. Pros and cons. Is early detection something that is possible? Somebody want to take that?
Maybe I can take it from the research perspective.
Yeah.
Because in the research, we always say, okay, everything is possible. I think the hardest point is trying to find something that will be very sensitive and specific. And I think there are things that sometimes are there, but we do not understand the biology. And so we kind of say, maybe that's not it. So I think definitely there is a future for early detection, and it's something that is really, because I think prevention at some point will be easier than treatment.
There is a lot of discussion about the benefits of early detection. Dr. Rutherford.
So we've looked at early detection over the number of years. There's a GOG trial, GOG 199, that actually looked at early detection. And what we did find, there are some subtle changes in the CA 125. However, it is very difficult to use that as a complete marker. Dr. Moore and I actually looked at 4 different markers, probably about now 20, 25 years ago. One of the markers was the CA 125, and we had some hopes for that. What we did find over the years is apparently the ovarian cancer starts in the fallopian tube, and during ovulation, what happens is that scar that's formed during the rupture of the egg and the follicle, you have the abnormal cells bind to this area, and then you have reepithelialization of that ovary such that these cells lay dormant. So that's really a major challenge. Obviously, some of our research is looking at trying to see, can we find the early changes even in the fallopian tube that actually will lead to this, and we have research going on. The best thing we have today is the CA125 and ultrasound every 6 months, and unfortunately, we still find patients with advanced disease that even trying to screen for it.
Yeah, thank you. And again, we hear a lot about the putting the patient in this stress. Okay, so you detect early, so what do? If it's true, if it's not true, we know with mammography, there is a lot of discussion with the prostate antigen. How about ovarian cancer? Really, we should be looking for more markers. We should work in finding markers for ovarian cancer, or is an area that is dead?
Well, I think one aspect that we can think about is beyond the markers, is not necessarily detection, but prevention.
Okay.
And since there's more and more data that the ovarian cancer originates in the fallopian tube, people who are at high risk, right, they can have prophylactic surgery. And even people who are not at high risk, people talk about this opportunistic taking out the fallopian tubes. If you have another surgery, taking out the fallopian tubes, apparently it's a pretty easy procedure and could have prevention effects because after childbearing age, the tubes are not really necessary, but I'm not a surgeon.
So that is a very good point, and I remember that I will bring either to you, Dr. Gogoi, when I remember when we talked several years of the prevention with the fallopian tube, they jump and they say it was a crazy idea, removing, and the complications of the surgery, doesn't make sense. Where are we today with that, Dr. Gogoi? And then we've got that. Still, we're screaming that it's a crazy thing?
No, I think that I think most GYN oncologists would sort of espouse the idea that, taking out the fallopian tube at the time of doing a hysterectomy is a reasonable approach. And, the data suggests that it takes you maybe 15 more minutes. There's no increased blood loss. It doesn't affect.
Could you explain a little how you will do that?
Yeah, so it's pretty simple at the time of a hysterectomy.
That is in the removal of the uterus.
Yeah, during the time of removal of the uterus, it's fairly easy to take out just the fallopian tube, which is attached to the uterus itself. And really, the data should suggest that you don't harm the ovary in any way. You can leave the ovary behind and still take the fallopian tube. And it really only takes another 15 minutes of time, maybe even less. I think to the point, I think the other thing in terms of early detection is identifying patients that are at risk. So, before 20 years ago, we didn't know BRCA1 and BRCA2 were risk factors for developing ovarian cancer. Now that panel of genes has gotten a lot bigger. So I think the more we're able to predict which patients are at risk, the better job we can do in terms of prevention.
So we'll talk about the risk. This is very important. But let me ask you, Dr. May, what is the age, if a patient comes, what is the age that you will consider to do the removal of the fallopian tube?
So that depends. Like with most things in medicine and in life. So if you're talking about an opportunistic removal of the fallopian tubes, that could be done at any age. So if someone is having heavy bleeding for other reasons, they're getting their uterus taken out, they've tried other mechanisms to try to prevent that, then you could take them out whenever you're taking the uterus out.
But in terms
But
of
in
the
terms of
prevention
genetic
of
risk-
ovarian cancer.
So the answer is we still don't know that. So the recommendations right now are still up in the air. So even for pre-RCA1. So we have women, right now, we have a trial that's open through our national.
That is
research
patients who have a mutation
have a
in the
mutation
gene
in the
BRCA.
gene and are at extremely high risk for ovarian cancer. That trial right now is looking at what we call staged removal. So meaning that for patients that are premenopausal, can we take out their fallopian tubes first and get a reduction in the risk, but not cause harm by taking their ovaries out earlier than necessary? So that trial right now is actually getting close to accrual for the first stage. So we'll have that answer actually relatively soon in terms of ultimately follow-up. Will that have, the risk reduction that we need? So the answer is how early? Typically, we recommend risk reducing surgery, and then that depends what that means, about 10 years before the first person in their family had it. But there are some people that never had a family member with ovarian cancer. Exactly, and they may still have a genetic risk that is just what we call low penetrant, which means that it just didn't show up before that person. So in those patients, the answer is, again, it's a discussion between you and your provider to discuss when it's opportunistic time.
But maybe that's something that maybe we could like develop. Before we open for the public, Dr. Rutherford, in your opinion, there was a time where in the media, all these actresses will go and say, oh, let's remove the ovaries. What do you do now? Ovaries or fallopian tube or both?
So if they're currently what we're doing, if somebody's done childbearing and they're over the age of 35 with a BRCA1 mutation, we would take out the ovaries. Well, let me expand upon that a little bit. If they are BRCA1, and if a lot of these patients we're seeing are coming in with an estrogen positive breast cancer. And these women were taking the tubes in the ovaries plus or minus the uterus. If somebody's just coming in for prophylactic and we know that they're a BRCA2, we know that their family generally doesn't have an ovarian cancer till the 60s or 70s, we would go in, take out the tubes, leave the ovaries until they're postmenopausal. I think everybody has to tailor this to the patient's history. The family history is critical, and what is the genetics telling us, and then what other diseases are you playing with? People who have breast cancer, we know the next cancer they're probably going to get is ovarian cancer. Just like people with ovarian cancer, we know the next cancer they're probably going to get is breast cancer. So I think you have to tailor each patient to what the family history tells you, what the genetics is, and you have to sit down and have a frank discussion with the patient, because bottom line, there's nothing hard and written in a book somewhere to tell you what to do.
Thank you. So let's do a break here. You might see if any participant would like to put a question here to the panel. You can do it either by the chat, or you can unmute yourself and ask the question directly to the panel.
I actually have a question on like a follow-up to what was just said. So my grandmother has had breast cancer twice. And so now I'm curious, how does that affect both me and my mother going down the line of risk then when it comes to breast cancer and ovarian cancer?
Open.
So
Was your grandmother tested for one of these cancer susceptibility genes or not?
Not to the extent of my knowledge.
is she still alive?
Yes, she is. She had a double mastectomy.
Okay, so she would be the first person you need to get into a genetic council. What we're looking at currently is a 77 gene panel that we're sending out and looking at what is her genetic makeup. So when you talk about your genetic makeup as a person, you're talking about germline DNA. When you talk about tumors, you're talking about somatic DNA. So what you want to do is get your grandmother tested for BRCA. Based upon what you find with her would give you a direction on what her siblings, her children and grandchildren would need to be tested. It not only needs to be tested in a female to female, but you need to test the males too, because you can pass directly from a male down through his children, breast cancer, and a male can get breast cancer too. And we treat a lot of patients with male breast cancer, and the males actually tend to do much worse. So it's important that your grandmother's tested, and then based on that testing, the rest of the family should have a profile done on them as well.
Please go ahead.
I would add that, so there are two possibilities, right? One is that your grandmother has a gene or mutation or does not. If your grandmother has the gene mutation, then each offspring, meaning your mother, uncles and aunts, you know, they have a 50% chance of inheriting the gene mutation, which means that they have a 50% chance of not having the gene mutation. So, for example, your grandmother is positive, but your mother is negative. Then you and your brothers and sisters don't need to be tested. If your mother is positive, then you should be tested as well, and your siblings, and you have a 50-50 chance of having the gene mutation. Now, if your grandmother is tested, chances are that she will be negative.
Good, you confused me already, so that's good.
So what happens then if your grandmother is negative? Well, she had breast cancer.
That could be what Dr. Rutherford was saying, the father.
No, because the grandmother had breast cancer.
Okay, breast cancer twice, that's true.
So there's still a risk that maybe there is a gene that we have not yet discovered, and the recommendation would be that you know, the mother and you would start screening for breast cancer at least 10 years earlier than the first breast cancer in your grandmother. So if your grandmother had breast cancer at 50 years old, then your mother should start mammograms at 40.
But I think also reading a little, trying to understand what the person asked, if somebody has breast cancer, is the daughters also in risk of ovarian cancer? Is two complete separate things?
They can be depending on the genetics.
That's difficult. That's not what happened.
What you really need is a geneticist that looks at the family pedigree. Because you got to remember, just because your grandmother had breast cancer does not necessarily put you at an increased risk. But then if you look at your grandfather's side of the family and they're having pancreatic cancers and prostate cancers, then you may be at a higher risk. So again, the best thing to do is to get to a genetic counselor, let them do a pedigree of the family, and then give a risk assessment after the panel is obtained on your grandmother.
And I think now the technology is there to do this kind of things, yeah, which is very easy. And it's recommended, you will recommend that. Thank you.
Well, thank you. Thank you so much. I was just gonna say that puts a lot into perspective because my grandfather's also had prostate cancer. So I think I'm gonna talk to my parents a little bit more and get some more information about my grandparents. Thank you guys so much.
Thank you. Let's talk a little more about the contribution of the father. There's always we think, oh, if we look only the mother passed where is involved the father in terms of a risk for breast and ovarian cancer? Somebody cannot hear?
What if the father has a BRCA mutation, he has a 50-50 chance to pass it down to the offspring, the same as the mother. It's just that with the father, sometimes they won't have breast cancer or ovarian cancer. They might get prostate cancer, which could be kind of overlooked.
So that the Lynch syndrome, the famous syndrome. That's correct. Can we talk a little about that? And since we're in the genetics.
The Lynch is a very different type of syndrome. So that's
Okay.
more associated with GI, colon cancer, truthfully even stomach cancers, but also
Prostate cancer.
prostate can be less likely, but for endometrial cancer and ovarian cancer, and there's actually now more data coming out that certain gene mutations that lead to Lynch can also lead to an increased risk for breast cancer in certain families.
Okay.
So
the paternal history we should take in consideration.
So anyone that has a significant family history of cancer should see a genetic counselor. just because you have a family history does not mean that you have a syndrome though.
Yeah,
And so that's really important. So it's important to have someone that knows how to dissect this to be able to then make the recommendations based on it. So that would be my recommendation to most of my family and friends is that if you have a significant family history, you should see a genetic counselor so then they can map out the pedigree, as Dr. Rutherford said, and then make a decision with you and them whether you should be tested. Just
Perfect.
because you have a cancer doesn't mean you should be tested.
Absolutely, yeah.
The other thing that's important is pancreatic cancer now falls into the category of things that should undergo genetic screening, so.
So if the father had pancreatic cancer, it should be also a good reason to the daughters to go screen.
Correct, and there are also certain ethnic groups that are at much higher risk for having BRCA mutations, for example, Ashkenazi Jewish population. There are some Asian populations that are at higher risk. Those should probably undergo genetic screening even in the absence of anything else.
And I think we will go at the high risk in a minute. We will continue answering some of the questions of the public. There was a hand that we answered that question.
They asked here, but first this one came
Okay,
first.
someone talked today about lipids and cholesterol. Can you explain in layman terms how cholesterol and the blood sugar diabetes potentially affect ovarian cancer and possible recurrence?
So there are no definitive
That's
data.
you.
Yeah. There are no definitive data in humans, but from the mice, we know that a high-fat diet can increase the risk of metastasis. It does not increase the risk of getting ovarian cancer, but if the mice have ovarian cancer and they eat more, they have.
So let me rephrase a little. Let's make it so you say that changes in the levels of cholesterol and sugar may feed the tumor.
It's
Is that
possible.
correct?
It's yes.
So okay, so how do we translate to myself? Let's say I like to eat a good burger every day, and I love chocolate. Yeah. What is my risk? I'm increasing my
There is
risk.
a wonderful study in melanoma that actually shows that chocolate and particularly the
Don't tell me it's not good because it's the only thing that I like.
the butter in
I'm
chocolate
going to take around and drink that I'm
can accelerate the growth of tumors, but this is all in mice, so it's hard to.
But
It's hard to.
I am your
translate to
patient. I
humans.
come and say I like chocolate. I have this situation.
I
What would
usually
you
say
recommend me?
Eat it.
Eat it. How much chocolate?
I usually, I'm more concerned with my patients eating healthy so that they can withstand the toxicities from treatment than all of these other concerns, because I think it's difficult. I mean, it's a difficult journey to go through chemotherapy and all the side effects of chemotherapy, and then have to add another layer of nutrition that there is no really convincing evidence that it would help.
Perfect. Dr. Alvero, I know you work about metabolism and all those complicated things. How would you translate also this question? What do you recommend?
Right, so at the cellular level, lipids provide positive energy to the cancer cells. So take that as, you really cannot get out of not eating fat anyway. It's very hard. But as you said, healthy diet, we were just talking about the intermittent fasting clinical trials that's happening. So those definitely worth a look at, but again, everything in moderation. I always.
Please, Mary.
Yeah, when I went through rehab oncology, 7.5 years ago, they immediately put me on the Mediterranean diet, and I followed that for years and years until I was really quite sick 1.5 years ago, and when I came out of that, I just wanted burgers. And I wanted steak, and I wanted, like a carnivore, I just needed meat. But I have gone back to, I do have a lot of dietary struggles due to treatment and other pathologies that have come about, and there is a lot to say for that. The diet piece and the Mediterranean diet is, it's a delicious diet, but it does have a big role in how you feel, how you're able to take, the treatments and recover from the treatments. And so it is a big piece, but I too like my chocolates.
Dr. Rutherford, what would you recommend to your patients about the burgers and the chocolates?
Chocolate sounds good to me because I eat it. What we do now, if you look at cancers that are promoted by somebody with increased weight due to maybe increased caloric intake and all, we know that breast cancer and ovarian cancer, or breast cancer and uterine cancers, are two cancers that people that are heavy and overweight tend to come down with cancers at a higher rate.
Yeah.
What we also know is some work being done by Tim Yateman has demonstrated that some lipids have the ability to enhance or inhibit cancer growth. And that's actually, there's a project being put together down with us that he's looking at that, and they're actually out for funding. It's actually pretty convincing evidence. Is it ready for prime time? The answer is no. But I do think if you eat healthy, try not to get overweight, because we know as you get overweight, you have an increase in inflammatory changes within the body. And inflammation causes cancer, and we think inflammation can cure cancer. It's just how do you manipulate it?
And the type of inflammation. Very good, thank you. We have a next question. Question immune therapy. Okay. I know this is immunotherapy is a growing field that has shown some success with various types of cancers. But ovarian cancer clinical trial seems not to show much success for immune checkpoint inhibitors. Do you think this can be feasible route for ovarian cancer treatment? And what advances need to be made in this field? Why don't we start with you, Dr. Winer?
So historically, single agent immunotherapy trials have not proven to be as successful as we had hoped. We're talking somewhere between 10 and 15% response rates in those single agent trials. That having been said, we now have a lot of newer drugs and combinations of drugs that are trying to turn the cold tumors hot, and that's an issue with ovarian cancer in general. And we're seeing, again, anecdotal success right now. We have some of these early phase trials that are now moving into phase 3 trials, which are the larger scale trials. And we have new trials coming into the phase 1 group all the time. So we have oncolytic viruses that are immunotherapies of some sort. We have antibody drug conjugates that are now working with immunotherapies. So we have a lot of research going into this, but it's not going to be single agent. This is going to be combination agents, typically for ovarian cancer. And so to answer the question, basically, is there's a lot of changes that need to be made. We have a lot of research going into it, and I think it's.
So we're not giving up to immunotherapy with
the investors might.
Can I put you in the spotlight?
Yes, of course.
Please. You're living that experience.
I'm living the dream.
You're living the dream.
Yeah, so, well, I actually just started virotherapy yesterday, so, we'll, I'm number 5 on this phase 1 trial. So this is exciting for me. I feel, really so fortunate that this actually opened up at the time that it did, because I was kind of without options, and have been for a few months. But I have been on some other clinical trials. I was on a phase 1 clinical trial with the ribociclib, but it was also concurrent with carbotaxol. It was rough. It was a dose escalation. I was 0.01 on the phase 1 trial. So that was scary. But I had my longest breach of disease. I made it 3 years without recurrence.
Fantastic.
Yeah, it was fantastic, but it came with a lot of heavy hitter side effects. I was definitely a roller coaster, but I just, you just have to do what you have to do and get through every way you possibly can. And, but so that's been my experience so far. I haven't had many immunotherapies. The Avastin, I was on that in combination with Cytoxan with topotecan. And I made it a whole year without recurrence or progression, I should say, because I still had disease, but I had no progression for a whole year. although it came with also some side effects, gross hemorrhage, hypertension, tachycardia. I'm still dealing with some of the side effects.
Side effects are still there.
Mhm,
They're still there.
exactly.
Because any new approaches, Dr. Alvero, that you think?
Yeah, it's very interesting, when lay people talk about immune therapy and they always say it doesn't work for ovarian cancer. I feel like they think that there is one immune therapy, but it's really an umbrella. And as Dr. Winer has said, there are oncolytic viruses that are on clinical trials. I am happy to report that we have a new publication that actually has just been accepted. And these are oncolytic immunomodulatory viruses. So it not only has this lytic effect, which is inducing cancer cell death, but also being able to modify the immune microenvironment.
Fantastic. So to put it in the case, so we always hear about the PD-L1 inhibitors, where it has the melanoma and other ones. That's not, seems to be no efficient in ovarian cancer, but doesn't mean that there is another approaches for ovarian cancer that may be more specific and more efficient, correct? Anything you want to add?
Well, I think we should not forget about CAR T cells.
Oh, yeah. Okay.
On the
Tell-
development.
I mean, now you confuse me because now I don't know anything about CAR T. Could you tell us a little more?
I'm not an expert in CAR Ts either, but these are cells that basically immune cells that are collected from the patient. And then they are processed outside of the body, make them recognize the cancer cells better and reinfused into the patient. And this CAR T
That's
cells.
kind of personalized medicine.
It's a personalized
Immune therapy. Yeah.
Right, and these CAR T cells have been approved and work very well for some of the lymphomas and other leukemias. But yet for solid tumors, they can work. If they work, it's great. But we still have to overcome some challenges. And I would have to say that I'm very grateful to all the patients that take part in trials, because we cannot advance this concept without your help. It's kind of it's frustrating sometimes that we don't get the results we want, but that is the only way we can make progress.
That's a very good message. Thank you.
I think we also need to think about, when we say all immunotherapy doesn't work for ovarian cancer is not the same.
That's
And
correct. That's
so,
another aspect.
we need to think about, there may be a specific subtype or a signature in specific types of ovarian cancer that perhaps would lend themselves better to immunotherapy than other types of ovarian cancer.
And I think that is a very important, maybe we will develop later based on the questions. We always talk, there is one, that we always talk about one disease. And we know in breast cancer, they are 100 years ahead of us, because they have subclassified so many types of breast cancer, and we still call ovarian cancer as a one single disease. We are behind, we have to change that. And let's see how we change.
There are a lot of.
We have a lot of questions now. There is a top question there. Let's see if I can translate. What could contribute to somatic mutations in homologous recombinant genes, such as BRCA gene, for example? That sounds Chinese. Who can translate that?
So I guess the question.
I'm sure, I really don't understand. Go ahead, maybe you translate that.
I guess the question is, how do tumors acquire somatic mutations?
And somatic mutations is just coming from my father and from my mother, is my tumor changed, correct?
Right.
How that is happening? I cannot blame my father for my problems. Who do I blame? The cancer. Dr. Robert, should have put that blame. If I cannot blame my parents, who do I blame?
Well, unfortunately, the tumor is going to figure out how it's going to survive. And there's multiple mutations within a tumor. And unfortunately, we really don't understand currently how these tumors, first, how do they start from a normal epithelial cell to go to a pre-malignant cell to go to a malignant cell? And I think that's actually going to be the question we have to figure out before we're going to ask, how does a tumor acquire somatic changes that are not within the germline?
It could be that inflammation causes kind of I don't know, inflamed environment, and under that kind of stress, mutations can occur.
So it's not only what I get from my parents, it's also how I live.
That's right, so
The
that,
type of
that
life-
inflammation can be linked to obesity or
Stress.
to talk. No.
Oh, we don't want to forget about that. Thank you for bringing, because I have a previous question about what is the role can talk and talk, but we will answer that because I see we have a lot of questions in the public. But let's not forget about that. I would like to hear your opinion. What is the role of talk on that? Okay, so Deborah is asking us, I want to know, okay, this is for the gyneconologists, the surgeons, an eternal discussion with the surgeons. Surgery for ovarian cancer is the zipper surgery, or is the standard of care now become laparoscope debulking? I suppose we're talking about robotic. I understand the woman have better long-term outcomes if they are debulked with a zipper procedure. Please clarify. Who wants to take first?
Start, you want to start?
We need Dr. Robert at the end.
So I think the first surgery that they're talking about is sort of the laparoscopy.
Laparoscopy.
So the
Laparoscopy.
standard up and down
But
incision.
let's use a term that everybody will understand. I like the zipper.
Okay.
I like the zipper. Laparotomy, I don't like.
Yep, so that is the up and down incision, that people stay in the hospital 4 to 5 days versus laparoscopic or robotic, which is sort of the smaller incisions where people go home. I think ultimately this is a decision that the surgeon makes, and it's based on a couple of things, right? If the goal of the surgery is to get out all of the cancer that you can, and really what we call minimal residual disease, which means that only microscopic disease is left. If the surgeon can do that robotically or laparoscopically, then that's a reasonable approach. I think that, at least for me, that becomes a little bit more difficult if you don't have your hands in the belly and are able to feel all of the surfaces of the abdomen that you need to
So
feel.
in your opinion, again, and we will pass to hear more, so the standard of care for you, what is the standard of care for you? The zipper or the?
There's not a standard, but my general approach is a zipper.
So still the dominant approach will be the zipper.
The time that sometimes we will do laparoscopic if they've got chemotherapy ahead of time, there's really no disease left on the CT scan, and you can do this laparoscopically. And the benefit of that is that the patient goes home the same day. The complication rates are much lower, the need for blood transfusions, infection risk, all of that is much lower if I can do it laparoscopically. But ultimately, whatever you need to do to get the goal of no residual disease.
That's too vague, But let's hear from Dr. Rothberg. We have those discussions many times. Let's hear your opinion. The zipper or the new technology, the robotics?
So I personally would not use a robotic approach for an ovarian cancer. That being said, I would not do a robotic surgery. However, if I need to get a diagnosis that we don't know what this tumor is, we can put a laparoscope in, which is a small incision in the abdomen. And I tell people we work through like chopsticks so we can get a couple biopsies to see what that tumor looks like. But if we're going to go to try to get somebody to no residual disease, and especially if I have them after neoadjuvant chemotherapy, where I'm going to use a high PEC behind that, we're probably going to make an incision. And we're going to take out the uterus, cervix, tubes, and ovaries, the omentum, the lymph nodes, any disease we see. If I have to take out the spleen, we have to take out a portion of the bowel, we'll take all that out. The other thing that I'm going to throw out to everybody is we're putting out a paper that's looking at the falciform ligament. And that falciform ligament looks like it's somewhere around 10 to 15% positive.
Sorry, let me interrupt you. Now you lost me. What are you talking about?
Falciform ligament is a ligament that's in the upper abdomen, and it's a fatty ligament.
So the ligament is the component that is holding all the tissues, correct?
That's correct. It links into the liver. And you can actually remove this with no major issues. But we often find
the liver will be floating there.
What's that?
The liver will be floating if you remove that ligament.
Nah, it's fine. It does just fine by itself. So for us, I would do an open incision. Now, a lot of people tell you that they love laparoscopic and they love robotic. I just have a paper that's just been accepted looking at minimally invasive versus open surgery. There was no difference in our blood loss. There's really not much difference in operative time. An open surgery, our patients go home the next day. Laparoscopic, many times, I would say it's 50-50, staying overnight versus going home the next day. If you look at a patient 2 weeks later, there's not a whole lot of difference between how these patients are recovering. It has to do with the open incisions. We tend to use a little more narcotics, and that's what screws us up as far as getting patients home. So for me, I think I can do and I made this statement in national forums, I can do an open case better than most people can do it laparoscopic. And obviously that raises a lot of eyebrows. But if you look at the paper I just put out, I finally, we also had the plenary talk at SGO that presented that a couple of years ago. So I do know you only do as well as your surgeon. And if the surgeon is an expert laparoscopist, and I know a lot of them, I can't do what they can do laparoscopically, and I wouldn't try. And
So
there's
your
some people,
standard, let's put it, your standard of care still is the zipper.
that's for me, but it's not as, I wouldn't call it a standard of care. How about my approach? I think it really comes back to the surgeon and what is a surgeon capable of doing.
Thank you. Anything to add to this, Dr. Winer? To add more chocolate to the fire?
Since we all love chocolate. No, I mean, I think, unfortunately, we see a lot of patients that had the Balkan surgeries done laparoscopically, and unfortunately, those are patients we call recurrent disease. So,
Oh, wow, interesting.
So the answer is for a true 3C disease.
Wait,
bulky.
3C, we
I'm
now
saying
are
it's
doing
bulky-
again.
Bulky disease.
Okay,
in
so
the
a
upper
patient who
abdomen.
has disseminated disease all over the abdomen, that you will call it a 3.
Then you need to get that out to the microscopic, and that's as you call it, the zipper.
The zipper.
But again, every patient is different, and if someone has an isolated mass in the pelvis and no other evidence of disease when you get in there, that still could be ovarian cancer, but that may be a patient that you can talk about minimally invasive surgery.
So important to have a discussion with
100%.
your physician based on your case, and also the expertise of the person who's seeing you. Thank you. So, wow, this is something that we did not discuss, and I don't know if somebody here can add a little. Is there an established role for the microbiome in ovarian cancer?
There was a beautiful paper not that long ago.
Can we talk a little first, what is microbiome?
So microbiome is the bacteria that live in the gut. And there are differences based on diet, based on use of antibiotics, based on socioeconomic situation. I don't know what else, maybe other disorders that the person has. There was a beautiful paper about a year ago that shows that the composition of this gut bacteria influences response to chemotherapy. This is in mice, I think.
Yeah.
But I'm certain that there are data in other cancers that this sort of gut bacteria may influence response to chemotherapy, and it's also very important that it also does influence response to immunotherapy.
Correct, yeah.
At least in other cancers. That's all I have.
So no, I think you bring the right point. We are more bacteria than cells. And we have to accept that the bacteria that is in our body is doing something. And definitely is regulating the immune system. But I think it's still in the area of cancer, the gynecological cancers, which I don't understand, because the female reproductive tract has more bacteria sometimes than the guts, the gastrointestinal tract. And we really have not even thought carefully, what is the role of the bacteria in many of the gynecological diseases? Yeah. So and especially gynecological cancers. I think we're very behind of understanding that aspect. Thank you for bringing that question.
This one's in reference back to the cholesterol question, the
Okay.
diet question.
Are statins then recommended to keep lipids in control?
They are recommended to keep lipids in control. I take a statin.
For prevention of cancer?
No, to keep lipids in control. But there is epidemiological data for ovarian cancer that the use of statin is associated with lower risk of ovarian cancer. Whether that is true or not, there are some pros and cons to this, interpreting this data. But there is such data out there.
Fantastic. Anything to add to that?
There actually was a study of prospective trial, looking at statin use in breast cancer. It's still accruing right now, to see if it actually, improves outcomes for treatment. It's actually being done here.
So it's an area that is really that we should follow and keep our eyes open how it develops. This is Mansoor. My mom died from breast cancer and ovarian cancer. Sorry to hear that. And she had 11 children. Good for her. She also was exposed to kerosene liquid and fumes. Could she have got cancer from breast cancer caused by the exposure to kerosene? And then she got ovarian. Thank you for saying. Thank you. That's a tough question.
I mean, the interaction between environment and your body is a tough question. It gets back to the top question. It gets back to a lot of these questions. The answer is, unfortunately, we don't necessarily know. There are a lot of epidemiological studies that have linked certain environmental exposures with all sorts of cancers. The problem with epidemiological studies and linkage is that it's more to bring the question forward. It's not definitive. And so the answer is we don't definitively know. But if she had these cancers, the other thing that she should be genetically tested as well.
But we're talking again, I mean, 11 children, there is a good protection, I mean, pregnancy protection and so on. Exactly, so this clearly suggests that there is an environmental component. That's what we're talking, we cannot blame everything on our parents. We blame also the environment that we live, what we eat and what we breathe.
And we actually know this from twin studies. There are a bunch of really good studies out there that have shown that identical twins in terms of disease, not only cancers, but we're talking about heart disease and other things, that environment plays a significant factor in terms of how people diverge over the course of a lifetime.
Correct. Dr. Rutherford, you wanted to add?
No, I think Dr. Winer actually hit it right on the head, especially with the twins. I would try, it really comes down to trying to live healthy and stay out of bad environments.
It's very important. It's very important. The environment definitely, and it's an area that we are understanding more and more, especially as our environment is changing so fast and how we will adapt. What is the next one?
Next question is here.
The utilization and less than, okay.
Back to the zipper.
Can we even remove the menton robotically?
Yes.
Yes. Everybody agrees with that?
It can be done.
Okay. We use the scan use of Lynparza continue for maintenance beyond 2 to 3 years for BRCA2 ovarian patients. Is it any research suggesting continued use?
No.
Very good question.
No, good question. We have patients on it.
It's a very good question.
So,
it's a very good question.
So the data actually suggests after 2 years, the newer data, and this is follow-up data, suggests that it might increase side effects.
Yeah.
And long-term side effects like myelodysplastic syndrome, which is
anything
also
chronic is a question.
But we do have patients that were on it for quite a while from the original studies. Not all of them had myelodysplastic syndrome, of course. But there's no data that going past that 2 years significantly improves outcomes.
I mean,
Go ahead, Dr. Go.
the data on the study for Lynparza, for example, suggested that the effectiveness or the therapeutic efficacy of Lynparza stayed on long after you stop the drug. So, even though the study stopped at 2 years, what you see is that the curves didn't converge, meaning that drug, whatever preventative effect the Lynparza had, continued.
There is a
on.
long-term effect even in the absence of the drug.
And in the setting of.
So
as Dr.
in your
Winer
opinion, what is the time that you would suggest to achieve that long-term protection? Do we know?
With Lynparza, the study was 2 years.
So 3 years is what you advise.
2 years.
2 years.
Yeah, depending on the part.
And
So
for
Lynparza
the
is
other,
huge.
for the niraparib was 3 years, but those are empirical. Maybe 1 year it's enough.
We don't
Nobody
know.
knows.
Yeah.
So the problem with the studies is we didn't think anyone would honestly get beyond 2 years. So that
And they
was,
did.
and thank God people did, but that was why it was stopped. And so there's no FDA approval technically for beyond 2 or 3 years, depending on.
So by the way, I agree that the long-term effect is not recommended. A long-term use is not
It's
recommended.
not, but that having been
And there is
said,
a concern for
There's a concern.
leukemia.
Yeah.
And treatment-related leukemias have very, very bad outcomes. So, if there is no benefit beyond 2 years, there's no point in having the potential risk of leukemia that is basically deadly.
Next question, we have, no, she did not get tested before she passed away. That's the answer. So yeah, it's difficult to know, but we think it's, as we saw before, it's an potential environmental factors. I believe that's a good one. I believe that if men had ovaries, we will be further along on finding an early detection test as well as more effective treatments. What can we do as a patient? I am with you. I agree with you, Deborah. Yeah. What can we do as patients advocates to create more urgency for results? I'm tired of seeing so many women dying because they are diagnosed. I will bring that question to you.
Yeah, it's a great question, and it's something that we continue to work on. I mean, the coordination, I think from today, I noticed that having all folks from across different realms of the work that we're doing coming together in one place is very key. I saw connections happening that I know are going to advance research. I saw, survivor stories resonating with people who are either providing care or who are doing the research, who are then able to take that into account. So I think having conversations across different realms is a huge place to start. And coordination, because our voices alone, each of our organizations or each of our institutions alone isn't going to do this. It's us coming together in conversations like this and at tables like this, and with all of you online, that is really going to make it possible to take those steps, bring the attention.
But I think we need to move also to the level of the silent people. Look at the funding for ovarian cancer at the National Cancer Institute is smaller.
Absolutely.
Yeah.
And that's part of, if you're not part of the.
So I like that, if men will have ovaries, what we will do.
Right.
I'm going to buy that, I'm going to use that sentence from you. Thank you, Deborah.
Hey, Gil, you remember when we had one of the galas, we had Cokie Roberts there?
That's correct, that's many years ago.
And Cokie actually, unfortunately, she has passed away, but she actually stood up and during the gala, she was our keynote speaker. And she said, shame on all you people out here. You have not advocated for funding. And she was talking about how we as a group do not come together the way the group that works on breast cancer. The other side of the coin is there's more women with breast cancer than with ovarian cancer. So I think when you start looking at the money, they're just figuring out where they're going to put the money first. And I think that unfortunately for the ovarian cancer, I think we're getting a little better than we were like 10 years ago,
That's
but
correct.
it's still pretty sparse.
But I would have to say that advocacy has actually helped. And like the funding at the DoD has increased due to
Yes,
advocacy.
Advocacy.
It
It has changed from 10 years ago, yeah.
Patients and families who are involved in advocacy continue to lobby for increased funding. We cannot lobby because we are applying for the funding.
We are the.
But we would be we are grateful.
Well, I mean, up until helping organize this entire symposium, I had no idea ovarian cancer existed. But with, prior to this, I know about breast cancer because there's so much support and awareness for it, but there's just not, I've never seen or heard about ovarian cancer before. So if, I'm not a person of science, I work here, but I'm not a researcher, so I'm more with the layman and the regular people here.
The normal. Yeah, I agree.
So I understand, if we don't hear about it, then how can we voice the need for more research and more funding for it?
It's true. Angelina Jolie did so much for the idea of BRCA testing and self-injections, right? I mean, before that. So unfortunately, a vocal figure like her kind of has to bring it to the public's attention when really, I think that should happen obviously long before.
Absolutely. Mary,
Yeah, what with my background in what it was, and I was symptomatic for 6 months before, I was diagnosed, but in that interim, I had been, back and forth to my primary care physician twice, and then referred to, the gynecologist, and completely missed with all the hallmark symptoms presenting. And I was so dumbfounded about that, because when I was finally diagnosed, I presented with, I had a gallbladder attack, totally missed the gallbladder because they found the stage 2B ovarian cancer that was I was bilateral, they couldn't figure out where it was coming from. So what was astounding to me, working in the field, family members who work in the field, going to the doctor like every 2 months, miss, but my GYN oncologist said they hear this story all day long. So what do we need to do for primary care or other clinicians that your first, steps when you're ill? How does this get missed so repeatedly to the point where it is late stage by the time you get to the right
So
folks?
to that, in 2007, 16 years ago,
Mhm.
ish, there was a consensus statement that was put out by SGO, our society, as well as ASCO, which is the American Society of Clinical Oncologists, that basically said that any woman that has persistent symptoms of bloating, of urinary incontinence, of anything that goes on for 3 weeks or more, should automatically go see their physician. But again, to your point, is that this was 16 years ago, and it's still not.
It still is not, they call it the disease that whispers, and very few people, especially the obese, that will listen. So let me bring the question that, what are the symptoms of ovarian cancer?
Let me tell you.
Please, go ahead.
Yes, the bloating was so profound. In my lab coat, I would have to undo my pants and button my lab coat so I could even get through the day. Driving home, I couldn't even bear like my seatbelt across my belly. I had the most unusual bladder piece where I could not release the urine flow. It was almost like when you breastfeed a baby and your milk lets down, where it just feels like, ugh. I could finally just get to this point where I could release the flow, but it felt like knives were coming out, and the urgency of the urine piece. And then those were the two most profound that I had. But then I had weight gain. I had weird, like a weird piece where I felt hungry, but then, was very full with just a few foods. So I had all the hallmark symptoms, just textbook as could be.
And they miss it.
And even the gynecologist, she did not examine me. Had she examined me, I felt maybe she could have, felt something at that point, and just totally dismissed me. And I said, aren't you going to order anything? Some sort of lab work, anything? No. And
You're having too much Chinese food.
yes, exactly.
Change your
Well, I
diet.
have seen you're perimenopausal. Now you have a desk job. There were all these, you're 50. I was 50 years old. And like I said, my GYN oncologist, they said they hear this repeatedly, and it's all the same symptoms. When I got involved with all of this and then, saw all of this myself, I was like, I'm textbook. How did this get missed?
Dr. Rutherford, you need to talk to all the OBs and the primary doctors. What would you tell them to look and not to miss these cases?
I wish I could instill what we know into their head as far as symptoms, but like everybody's saying, unfortunately, most people have an ovarian cancer anywhere from 6 months to 2 years before it's diagnosed. And it is the disease that whispers. I always, on all the medical students and all the residents, I tell people, if somebody's coming in and has a new symptom, and they complain about it like once or twice, there's something going on. It's your responsibility to find it. And that's true for any of these diseases. I mean, pancreatic's the same way. Some of these lung cancers are the same way. And the question is, it's easier to say you're postmenopausal or perimenopausal age 50. You're getting old. For me, I had abdominal pain. I got blown off for a couple weeks, and I finally got so bad that I ended up getting CAT scans. It turned out, thank God, I only got ulcers. But, you know, it was easy. You know, you're old. I mean, we all are getting old. I get that. But I think part of it is people, I don't know if they just hear so many complaints so long they get immune to it or what the deal is. So you almost have to be your own self-advocate. And we should, part of the education, I think, like health education for women and men, we need to tell them here's the diseases that you are potentially liable to get, and here's some of the symptoms, and you have to pay attention to some of this.
Absolutely, and I agree with Susan saying, we need to do education and awareness, need to be across the board.
Right.
We are almost at the hour. I don't know, they have 4 new messages. Let's see. This is the symptoms.
And then there was one other question, which was, you know, what would be your overall message to everybody that we can
Yes.
take away from today?
So we will do that. We will go around the table. I give you 10 seconds to think what will be your message. And I'm sure everybody will again. Why don't we start with you, Dr. Rappaport, in the distance from North Carolina?
I think the message that's coming out of this seminar, you have a lot of very smart people that are working to try to figure out the cause of the disease and the treatment of the disease, and what's the best management for each of the patient. Real important for the patient, look at your family history. If you have a history of cancers or cardiac disease or whatever it is, you need to get that evaluation set, because also genetics plays a role in cardiac disease as well. So I think most people are going to ultimately need a profile of their family history to know how to take care of themselves in the future.
Thank you.
Well, I think we should be hopeful, because we've accomplished a lot in the past 10 years. We have many new drugs that have been approved. I think the pharma industry is paying attention to ovarian cancer. There are way more trials than we used to have. I think also the pace of discovery has accelerated. We know much more about the origin of ovarian cancer, some specific mutations that we might be able to address differently. So I would say that it's a message of hope.
Thank you.
Yeah, Dr. Matei took my statement absolutely, which is to have hope. You know, the people of today inspired me to try and think bigger, think collaboratively about how I can offer a better approach, how I can extend my patients' lives, all of our patients' lives, and that, you know, you have a lot of people that are working diligently to try and make a difference.
Yeah, I think overall message to the public, and I also want to give a message to my peers. So I think for the public is, as Dr. Rutherford said, you should be your own advocate. And you know, my 14-year-old told me only go to websites that end in org, edu, or gov. So make sure that when you're getting your information is legitimate. And then for my peers, I think, you know, innovation is logarithmically increasing. AI is here, but I think it also means that we have to really work as a team, and science is a team sport, and I'm happy to be part of this team. Thank you.
Yeah, I think those are all wonderful messages that I took away today. I'm excited to see what's all going on with folks. But I also want to highlight that how all of the different voices are super important in this conversation. So all of the survivor voices, the family members, you know, you all are contributing to the research and the directions that it goes, and all of the different perspectives and institutions that are coming together. So I was excited to see all of that.
Thank you.
I really got nothing to add. I think everyone did exactly what I would say, but I do think it is important. That's the one thing I would say is, don't be afraid to ask questions. Not only be an advocate for yourself, but don't be afraid to ask questions, whether it's your primary care doctor, whether it's your friends, whether it's your physician that's treating you for whatever you have. If you don't ask the question, then the answer is always no. So gather whatever information you can.
Mary,
Absolutely. You know, all of the above here for sure, is also my main thought, but having been, in this patient role, which has been so eye-opening, and I don't know how lay folks actually get through it, to be honest with you, because the patient perspective, for me, the advocacy of, for yourself is so important because, so much can get missed. So, you know, right from the get-go, right from my diagnosis on, and mistakes happen, adverse events happen. And I think that level of communication, you begin to feel like, am I a pest? Am I bothering these doctors or whatever? But there's no way when you see 50 patients per day that you can have on radar every single patient that maybe not be doing well, or maybe they are doing well, but things are developing. And I just feel like patients need to find some sort of segue to be more candid and be more comfortable having conversations, if it's not actually with the physician themselves, but maybe a mid-level that they can, you know, have a little bit more time in clinic talking about what is truly going on. Because that's, the wellness will transcend with the less, you know, problems. And there's a lot of problems with every single solitary step. And I have a tremendous support and, you know, resource font that I can, you know, and it's still so difficult for me. So I really think about those lay folks or the folks that don't have a good support network. It's just, it's a lot. And I'm sure a lot of folks are withering on the vine, maybe not, you know, getting the biggest bang for their buck with
Yeah.
treatments and
Yeah.
therapies because of that.
thank you, Mary. You know, we covered only 20% of the questions that we received before this study. Yeah. So just tell us how much the people are hungry for knowledge. So my friends, first of all, I want to thank you for making time, but I want to drop you that this is just the beginning of our work. We need to answer questions. We need to talk to the public. So I know that all of you are very busy. You would like to be now at home with your family having dinner, but I think putting aside a time to answer all these questions is our obligation. And I'm looking forward again. This is the first one of many more to come until we answer all the questions that I received. I want to thank also to everybody who participated, including the panel here and Dr. Rutherford, and for all the fantastic questions. We will have a continuation of this panel in a very near future, and we hope we can answer more of your questions. Again, thank you and have a wonderful night.
Thank you.
We can stop.